Have another great presentation coming up. We have Dr. Douglas Krakower, who is the faculty in the Division of Infectious Diseases at Beth Israel Deaconess Medical Center. He's also a research scientist at the Finway Institute and also associate professor in medicine at Harvard Medical School. His research focuses on ways to optimize HIV prevention in healthcare and community settings with a focus on implementing HIV pre-exposure prophylaxis, PrEP, and his clinical practice emphasizes general infectious diseases and HIV treatment and prevention. So Dr. Krakower, please get started.
Thank you, Linda. It's really a pleasure to be here. I will share my screen. Okay, are you able to see that, Linda?
We're good, Doug. Thanks.
Okay, great. So I really appreciate the chance to talk to all of you about biomedical prevention of HIV and STIs. And we'll talk a little bit about HIV and then a little bit about a really new exciting development in STI prevention called DoxyPEP that people may have heard about. And we'll try and leave time at the end for questions because I'm sure there are so many with these pretty new topics. So here are my disclosures. I just wanted to spend a little bit of time in the spirit of what Ava was talking about before in terms of the background epidemiology to get a sense about what's happening with the HIV epidemic in the US. And these trends would mirror what's happening in Connecticut. The most recent data from CDC that are reported in their sort of statistics are new diagnoses in the US of 36,000 or so for HIV, which is a little bit less than the about 10 years before, but it's been really incremental decreases and it hasn't been the dramatic drops that people have hoped for with new interventions like HIV pre-exposure prophylaxis or PrEP, which we'll talk more about. And the epidemiology still includes very highly disproportionately affected subgroups with almost 70% of new infections among gay and bisexual men or other men who have sex with men, a quarter among heterosexuals, and about 7% among people who inject drugs. And the epidemiology in 2022 is very similar to this. There haven't been any dramatic changes. And if you dig down a little bit deeper in terms of some of the most affected subpopulations, there are really important racial and ethnic inequities in the HIV epidemic, where people who identify as Black African-American who are having male-to-male sexual contact, which you identify as MSM, is by far and away the largest subpopulation, even though that group does not make up a huge percentage of the overall populations, which suggests that the inequities need to be addressed. The same is true for Hispanic and Latino identified MSM, and then after that is white MSM. And for people who identify as cisgender women, you see the same sorts of inequities with higher rates among Black African-American and Hispanic women. So all of these inequities need to be addressed if we're going to have an impact on the HIV epidemic at large. And I just highlighted these inequities here in these blue boxes. There are also important trends by age that are important as STI clinicians to think about as you're seeing people who come in, concordant with the data Ava showed about higher rates of some of the bacterial STIs in the younger subpopulations. The number of new HIV diagnoses was greatest among people aged 25 to 34. And actually, there's still a very large number of infections amongst people 13 to 24, most of those in the older end of that spectrum. But you can see across the entire age spectrum, including people age 55 and older, there are new infections occurring with HIV. So anyone who walks in the door, particularly in the context of sexual health care, could be someone who would benefit from more intensive education and discussion about HIV prevention. So there are geographic inequities similar to the bacterial STIs with the highest rates on a per population basis in the southeastern US, but the northeast US comes in second, and then the West and Midwest after there. So what's the big revolution that we're here to talk about? It's PrEP in terms of HIV prevention. And this is an intervention where people could take antiretroviral medications that have been used for HIV treatment before they come in contact with HIV to prevent acquisition of the HIV virus. People may have heard of it in this group, and I'm sure there's a spectrum of familiarity with knowing about it and talking about it and offering it and maybe even prescribing it depending on people's backgrounds. But for the purposes today, we'll probably have some information that's more basic and some that's more advanced so that everyone hopefully can learn something today. But this was FDA approved in 2012, so we're now over a decade into the PrEP era. But as I will talk to you over the course of this talk, it really has not had the uptake and the impact that we had hoped for, even though it's incredibly effective. So how effective is it? Well, the first PrEP agent that was identified as effective was something called tenofovir disoproxil fumarate with emtricitabine. It's a mouthful. It's TDF-FTC is the abbreviation some people use. The brand name Truvada, which is a little easier to say. Now it's actually available in generic, so it's quite cheap, but sometimes people still refer to it as Truvada as PrEP. But there are lots of other agents, as we'll get into. So how effective were the early studies looking at TDF-FTC as once daily HIV PrEP? Well, these are actually some real world data from Kaiser Permanente in Northern California, which is an integrated healthcare system. And this is an observational study after PrEP was FDA approved and it was being prescribed by clinicians. It was pretty slow out of the gates for the first couple of years, but some researchers there, a colleague of mine, Julia Marcus, who's now actually at Harvard, looked at whether there were new HIV infections among people using PrEP in the Northern California branch of Kaiser Permanente. And they looked at the first 5,000 or so person years of PrEP use. And what's really interesting is that over this time period, they noticed lots of STIs. And I should say that about 98% of the people who were early adopters of PrEP in Northern California were MSM. And so it was a population where there are already high rates of HIV, but also bacterial STIs. So they looked to see if people who had STIs were acquiring HIV while using PrEP, because we know from the epidemiology, as everyone in this audience knows all too well, that bacterial STIs are synergistic with HIV. And so where you see bacterial STIs, you're likely to see future HIV acquisition events. So in the cohort that they looked at, 42% of the people in the cohort had at least one bacterial STI, including over a quarter with rectal STI, gonorrhea or chlamydia. 7% had syphilis, which we know are strong predictors, rectal STIs and syphilis, of new HIV infections. And what they found is that there were 0 HIV diagnoses, 0, not a small number, but none amongst people using PrEP. So this really, this made the New York Times, and people really said, wow, this intervention is not just something that people will take in clinical trials, it's actually something that can have a major impact in terms of having an impact on the HIV epidemic, not just in Northern California, but more nationally. And after that, things tended to pick up a little bit. So in terms of the clinical trials data looking at PrEP use, if people use it optimally, they take it daily or close to daily, missing the occasional dose. Among men who have sex with men, there have been a bunch of clinical trials and it's over 99% effective. There have been, I can count on my 2 hands the number of case reports of people who have had appropriate daily use of oral TDF-FTC and have acquired HIV in the literature. So it's that good. Now, a lot of people have trouble taking it. It's more of a biobehavioral intervention. You have to take the pill to get benefit. And so that's always a challenge. But if people do, it's virtually 100% protective. Amongst heterosexual men and women, there was a study in sub-Saharan Africa that showed it was also 99% effective amongst people who took it as directed. And there was a study in Thailand looking at people who inject drugs. And again, 74 to 84% protective. So really, really effective if people can take it. The federal government has had an initiative called the Ending the HIV Epidemic Initiative that was launched in 2016. It's been a little bit delayed by the COVID pandemic that came on, but their goal is to reduce the number of new HIV infections in the US by 90% by 2030. So that's 7 years from now. So this is a big ask. And they have 4 major pillars that they think will get us there, or at least close to there, hopefully. One is to diagnose people with HIV as early as possible. Second is to treat people with HIV rapidly and effectively to reach sustained viral suppression, which is good for their own health, but also prevents forward transmission, as we'll talk a little bit about. Prevent new transmissions using PrEP as the major intervention, and also syringe services programs, which are very effective as well for people who inject drugs and have parenteral exposure to HIV. and then respond quickly to potential HIV outbreaks using sophisticated epi-molecular and on-the-ground methods. So PrEP figures prominently in the major plan to end the HIV epidemic in our country. But unfortunately, uptake has been slow and very inequitable. So the CDC released a modeling study a few years ago asking, what is the estimated lifetime risk of an HIV diagnosis among MSM by race and ethnicity if there's nothing better done in terms of accessing HIV preventive care and services for these populations? They estimated that African-American MSM would have a 1 in 2 chance of a lifetime diagnosis, which is a public health emergency on the order of congenital syphilis, as we were talking about before. So this is a real problem. And for Hispanic MSM, 1 in 4, and then for white MSM, 1 in 11. But PrEP coverage, as of a report issued in 2021, showed that of the people who identify as Black in the US who have CDC indications for PrEP, which we'll talk about, only 8% had ever accessed PrEP, so far below what was needed. For Hispanic populations, only 14%, and for white MSM, it was much, much higher at 63%. So it shows that this is something that can be rolled out if people have access to it, but the racial inequities need to be dealt with for sure. Some of the barriers to access to PrEP amongst racial and ethnic subpopulations include stigma around HIV and to some degree around PrEP. Healthcare has structural racism, unfortunately, built into the structures in terms of health insurance and access, which all trickles down to poor outcomes in terms of STI, HIV prevention, and PrEP access. The cost of the PrEP care, if people are uninsured, there are actually great ways to get people on PrEP using patient assistance programs, and the federal government will offer the drugs for free. So there actually are great opportunities, but people worry about the cost, and that prevents them from coming in to try and get it. And then a lot of clinicians are not comfortable with engaging in HIV risk assessments to see who might benefit from PrEP. As sexual health clinicians, as Ava mentioned at the end of that talk, which was really wonderful, having these conversations and educating people about PrEP is a really important first step. And you all are in prime position to identify people who may benefit from PrEP because you're seeing an enriched population of those who have bacterial STIs and other potential exposure covariates. What about Connecticut? How is PrEP being used thus far? There's a great resource called AIDSview PrEPview, and this is something that is run out of Emory, and they actually use retail pharmacy data, so it's not complete data, but retail pharmacy data from around the country to post rates of PrEP prescriptions by, you can get it by state, you can get it nationally, you can get it by county or zip code, so it's really granular stuff. And I encourage anyone who's interested in learning more to dig in deeper. So I just went ahead and pulled the PrEP data from PrEPview on the state of Connecticut to get a sense for things. And as of 2021, there were over 3,200 people who had used PrEP in Connecticut. And you can see in terms of the breakdown by gender, 92% male and only 8% female. In terms of race and ethnicity, there was about 20% Black and Hispanic Latinx versus 67% white. So again, kind of mirrors those national data I just showed you. And by age, you can see it being used across the age spectrum with appropriately the highest rates in those age 25 to 34. So just to highlight again these inequities that are so critical, only 30% of PrEP users were racial and ethnic minority persons in the state of Connecticut, even though we know that the diagnoses lean heavily towards those racial and ethnic minority populations. They've calculated something called the PrEP to need ratio on the PrEPview site, which is really cool metric for thinking about whether there are rates of PrEP prescription in particular subgroups that match the incidence rates. It's actually just a ratio of number of PrEP prescriptions in a subgroup divided by the number of new HIV infections in that subgroup. And so this is for Connecticut. And so the higher PrEP to need ratio is, the better you're doing in terms of covering the need. The lower is, the more work we need to do to get more PrEP prescriptions per HIV diagnosis. So looking at some of the key statistics here, we can see that the PrEP to need ratio has gone up from 2012 when it was first FDA approved to 2021, which is great. It means you have about 16, sorry, this is a bit small, but about 16 to 20 or so PrEP prescriptions per new HIV diagnosis. And if you look to the left here, for men, it's around 23 is the PrEP to need ratio. For females, it's about 5. So there's far lower use of PrEP amongst people who identify as female. So that's something that needs to be addressed, even though there are more infections amongst people who identify as male because the MSM subpopulation is so heavily affected. We still are doing an even poorer job of getting PrEP to females. In terms of racial and ethnic subgroups, no surprise given the themes I've already talked about. For Blacks, the number is almost 6. For Hispanic and Latinx people, it's almost 11. And for whites, it's almost 42. And again, a higher number is meaning we do a better job. And then for the age ranges, it's pretty equal across the age ranges. And we're actually doing a pretty good job amongst identifying people who are age 25 to 34. So these kinds of data, I think, can be really helpful on the local level to think about populations need to do more work with. Okay, so how do you think about PrEP in terms of clinical practice? The CDC has released practice guidelines since the advent of PrEP in 2012. They most recently updated these in December of 2021. It's a real comprehensive guideline. It's like 150 pages. So if you need something to put you to sleep, this is great. I mean, all kidding aside, it's a great document with lots of resources. It is rather long, but they have some great figures and tables. But I'll just review some of the highlights here so that people can take away the general sense of what PrEP is and how to prescribe it. And I know from the chat that some people are already doing this, which is great. Here's one sort of semi-interactive question that people can think about. This is a typical case. A 25-year-old cisgender man who has sex with men has a new diagnosis of rectal gonorrhea. He would like to start PrEP. What are PrEP options for him? So there's daily TDF-FTC, there's daily TAF-FTC, and TAF is tenofovir alafenamide, which is a slightly different formulation of tenofovir. And the brand name for this medication is Descovy. It's not available as a generic, so it's far more expensive than generic Truvada. But that's another potential option. There's on-demand TDF-FTC, where you just take the medications right before and after sex. There's on-demand TAF-FTC, and there's injectable cabotegravir. Cabotegravir is a long-acting agent that can be given as an intramuscular injection in the buttock, and it has a very long half-life, so you can give it every couple of months. So in terms of interactivity, I know this is a big group here, but I'm curious if anyone would put in the chat anything that they think is an appropriate PrEP regimen. Okay, daily 2-in-1 for men, 1 is 1, yes. Okay, great. Well, let me jump in and go through what are the options here. And again, this is what I call the most advanced part of the talk, in that it's getting into kind of the weeds of what you actually can prescribe here. But in terms of things that are recommended, you actually have lots of different options for this population, which would be a sort of otherwise healthy MSM, including 2 daily options, an on-demand option, and an injectable option. And we'll talk more about these. Okay, so let me just review all the PrEP options in brief to give you the 36,000 feet overhead view. So as I mentioned, there's daily TDF-FTC or Truvada, which is available as the generic form. It can be used in any population, including people who identify as any gender, any sexual orientation, if they have sexual or parental risk through injection drug use. This is a good option. Tenofovir can have some impact on kidney function, so it's recommended to have a creatinine clearance over 60 to use this. And it is active against hepatitis B. So if someone has hepatitis B, you would be treating their hep B with this agent as well. So you just want to know about that. And the recommendation is to test people for hepatitis B before starting it. The next option, as someone mentioned in the chat, which is really great, is called on-demand or 2-in-1 version of the generic Truvada TDF-FTC. Can also be used with the brand name, of course. This is where you can take 2 tablets between 2 and 24 hours before sex, and then another tablet a day later, and another the next day, hence the 2-1-1. So for example, if someone knows they're going to have sex on Friday night because they have a planned hookup or something like that, they can take double dose of Truvada during the day on Friday, have sex Friday night, and then take PrEP, a single dose on Saturday, a single dose on Sunday, and then be all done. And this has been shown to be extremely effective, and in fact, just about as effective as daily PrEP for people who can plan ahead and are organized enough to remember to take the pills in this way. So this 2-on-1 regimen is also a really great option. It's only been studied for MSM, so it's not yet been recommended for any other population by the CDC. But for MSM, which is an important subgroup, this is an option. Same caveats around creatinine clearance. Then there's a newer daily PrEP option, TAF, FDC, or Descovy, which has only been tested in MSM and transgender women. The tenofovir alafenamide is a little bit easier on the kidneys and also the bones than TDF FDC, which is still very, very safe. But for people who already have osteopenia, osteoporosis, or have some known chronic kidney disease, this would be a potential option for those populations. And here you can use it with a creatinine clearance 30 or above. I'm seeing from Ellen Struziero some success getting started with 2-on-1 and discussing daily doses injectable. That's great. So it sounds like this is happening in really cool ways in Connecticut. And so this will be wonderful for the discussion part to hear more about your experiences. So as Ellen mentioned in the chat, or alluded to, there's an injectable option, cabotegravir. It's an integrase inhibitor, as I mentioned, is long-acting. It's given in the buttocks as an intramuscular injection. And then the first 2 doses are once a month. So you give an injection, you wait a month and give a second injection to load. And after that, it's every other month, bi-monthly. This can also be used in all populations that have sexual exposure. The CDC, there have been no studies looking at its prevention in people who have injection-related exposures, but the CDC does say that because sexual exposure is so common amongst people who inject drugs, it's okay to use this as a PrEP option for people who inject drugs and also have sexual exposure, which again is the vast majority of people in actual clinical and community practice. So for all intents and purposes, this is also an all populations type intervention. It doesn't have any issues with bone or kidney, so it can be used with any creatinine clearance, and so that's a really nice option. It's just being rolled out. It's a little bit slow to get started because of some logistical issues, but it is a really great option. Okay, just to give you an overview of what the clinical follow-up looks like for oral versus injectable PrEP. At baseline, for people starting oral PrEP, you do an HIV 4th-gen test and an HIV RNA test, an STI screen, creatinine clearance, and a Hep B panel. I should mention the HIV RNA test is a relatively new recommendation from CDC. It used to be just the 4th-gen test, but they're trying to be a little more sensitive to identifying people who may have undiagnosed HIV before starting PrEP or while they're on PrEP. Every 3 months, it's recommended to get a 4th-gen and HIV RNA. Some clinicians have had said that it's too expensive or they have trouble accessing the RNA, and I think using just the 4th-gen is probably just fine. We did it for many years with no issues that we could detect. And then do STI screening, because if people are on HIV PrEP, they may be at risk for bacterial STIs. You should have a creatinine clearance every 6 months if people have risk factors for renal impacts of the tenofovir, which would be if they're over 50 years or if their baseline creatinine clearance is under 90. Otherwise, if they're healthy, it's every 12 months you do a creatinine clearance. And then for people who have exposure risk to Hep C, you do an annual check for Hep C as a routine screen. And then the TAF formulation, while friendlier for the kidneys and the bone to some degree, have been associated with slight dyslipidemia and slight weight gain, just on the order of a couple of pounds. So it's recommended to follow people's lipids and weights if they're on that agent. But overall, the agents are generally quite similar and all very safe and effective. In terms of the injectables, the idea is at baseline, you would do a 4th-gen and HIV RNA test, and then an STI screen. And then because people are getting injections every 2 months, the follow-up would be to get HIV 4th-gen and RNA tests every 2 months. When people are there for injections, you just get the blood test at that point, and then do STI screens every 4 months as part of general sexual health care. And then every 12 months, you would do the Hep C testing if there's risk for that. So fairly straightforward. And if people want to talk more about the details, we certainly can. In terms of the CDC's recommendation for who may benefit from using PrEP, they actually mention some tips that are, I think, more for primary care providers than for seasoned sexual health clinicians and providers, as is this audience. So I won't go into too much detail, but basically the CDC now recommends that everyone who's sexually active should be informed about PrEP, as was alluded to in the first talk. And so this is a great opportunity when you're seeing people for general sexual health care to say, hey, what are you already doing to prevent against HIV? Have you heard about PrEP? And then offering some information. And then if they're interested, taking next steps, which is either prescribing if it's available, or if not, at least people know about it and they can have a referral or a warm handoff to clinicians who might be able to. And so the CDC says here are the reasons that someone would have a strong clinical indication for PrEP if they're sexually active adolescents and adults, and they've had any anal or vaginal sex in the past 6 months, and any of the following, either an HIV positive sexual partner, especially if that partner is viremic, so they have an unknown or detectable viral load, which is the most transmissible status in terms of HIV. If they've had a bacterial STI in the past 6 months, which will come up a lot in the practices here, or if they've had history of inconsistent or no condom use with sexual partners. That's actually a much broader scope of people. And so they're really trying to get PrEP out there to the general population to have people know about it. Also, if people who have injection drug use and an HIV positive injecting partner, or if they're sharing injection equipment, which is the vast majority of people who are using injection drugs, have some report of shared equipment and would be qualifying for PrEP indications. So these are the general indications that CDC mentions. And I would add, as CDC does in their recent update, if someone requests PrEP, even if they don't disclose specific behaviors, they might not feel comfortable disclosing specific behaviors that may put them at risk for HIV. So if someone requests PrEP, it's recommended to give that, no questions asked. Okay, here's another interesting question about HIV prevention using biomedical interventions. A 28-year-old cisgender woman has an HIV positive cisgender male partner. He uses antiretroviral therapy to treat his HIV and has an undetectable viral load, as low as it gets. They have sex about twice a week, and they do not want to use condoms. Your counseling to them about HIV transmission is which of the following? Studies suggest that the risk of HIV transmission is still substantial. Studies suggest that the risk of HIV transmission is low. Studies suggest that the risk of HIV transmission is extremely low, or studies suggest that it's zero, or something else. What do people think? I'm curious if people can throw in the chat if anyone feels brave enough to say something here. We have 1, still substantial. Any other thoughts? 2, that it's low. Anyone for 3, 4, 5? Other is always the right answer, right? Because you can always say something more nuanced than what I can put in the. So 4, 0 by that's bold to say. We almost never say 0 in healthcare and medicine, right? It's like, how can we be so sure? Okay, well, it's great that people are brave. I really appreciate that. And here's what the NIH and Tony Fauci says. Studies suggest that the risk of HIV transmission is 0. So even though that sounds bold, there's actually incredibly robust data showing that if people have an undetectable viral load, HIV just does not get transmitted. And there are 2 big studies that you don't have to know all the details, but that highlight this. They're called the Partner 1 and the Partner 2 studies, where they looked at 888 HIV serodifferent couples. And they had heterosexual, they had gay couples, they had a whole heterogeneity in terms of sexual orientation was rich. They accounted for 36,000 condomless sex acts, including vaginal, anal, oral, you name it. They recorded it all. The research assistants were really diligent and had some big spreadsheets here. But the punchline is that if people in the partnership with HIV had an undetectable viral load, there were no linked transmissions, 0 out of, again, tens of thousands of sex acts over a bunch of years. They did a similar study with HIV serodifferent MSM couples. Again, people were versatile with anal sex as tops, as bottoms, you name it. And again, there were no transmissions when people had an undetectable viral load. Now, there were people who had HIV diagnoses as part of the study, but they looked at the genetics of the viral strain that people acquired, and they did not match their main partner in the study. So it suggests that they had outside partners. So of course, if you have other partners, having your main partner undetectable doesn't protect you against HIV there, which is why PrEP is such a great intervention, even if people are in serodifferent couples if they choose to. But you can tell them that there's no chance that HIV will transmit it if someone has an undetectable viral load. So that's a really important thing. And I can tell you in my practice as an HIV clinician, when I talk to people living with HIV about this, it is the most rewarding conversation because people have worried for years. Some people have stopped having sex for years because they're so worried about transmitting to other partners. And it's like, you can see people melt, like, I can't believe this is true and no one told me this. So it's a really important result to share with the community. Okay, so that was all about HIV and PrEP for the first half of the talk. And now I'm going to transition to the second half, which is DoxyPEP. Let me just see if there's anything important in the chat here. Okay, undetectable HIV viral load within what time frame of sexual encounter? Great question, because people may have an undetectable viral load, but then they don't get repeat follow-up for typically every 6 months. We check people's viral load. In the studies, they checked people who had HIV viral loads that were suppressed for at least 6 months. Now, people could have had blips and could have gone on and off therapy in theory, but in the study, if people had an undetectable viral load on their routine checks, there were no transmissions. So the general recommendation is that if people are undetectable for 6 months and more, you can offer this, what's been called undetectable equals untransmittable, or U equals U concept. And U equals U is also spread in the community to some degree. But I think that's probably very conservative, meaning if people are undetectable, which with modern day antiretroviral therapy can often happen within 1 or 2 months, quite routinely with integrase inhibitors, biomedically, there's no reason to believe they wouldn't already be non-transmittable. So good questions there. And we'll also have time. Yes.
Quick question, Doug, before we go on to the next topic for the PrEP. I would like to know your opinion on this viral load requirement for PrEP monitoring, especially for oral PrEP, Truvada. Somebody in the chat already mentioned that they were having a hard time getting creatinine clearance. So I think this requirement of viral load for PrEP monitoring would probably be a barrier to PrEP expansion. There might be a stronger argument for injectable PrEP from the studies, but I'm not sure how you feel about the oral Truvada PrEP and viral load monitoring requirement.
Yeah, I mean, I'm so glad you mentioned that, because I'm the messenger here of the CDC guidelines, but I actually think, as I kind of hinted a little bit, that the HIV viral load for people on oral PrEP is probably excessive, and that there's no reason to withhold PrEP care if you can't get that viral load. And I can say that most of the clinicians here do not send it routinely, because the 4th gen test is relatively sensitive. It picks up most HIV infections within, as we know, 14 to 21 days. When people are on PrEP, that's probably more like 30 days in terms of the window of detection with a 4th gen test. But that's well good enough, I think, for clinical practice, particularly because even if people acquire HIV while using PrEP, they can still use all the first-line regimens for HIV treatment. So most people have kind of shrugged at that guideline and have not tested the HIV viral load for people on oral PrEP unless there's suspicion for acute HIV, in which case it's a really good tool for people about to start PrEP, like if they have fevers or sore throat, or maybe if 5 days before they had a receptive anal sex with someone who had positive viral load, and they also had rectal bacterial STI, kind of like things that really increase your risk for potential new HIV diagnosis, like acute HIV, then the RNA test is a really good tool, but we almost never need to use it in clinical practice. For injectable PrEP, as you alluded to, I mean, I agree, it's more important because the sensitivity of 4th gen testing for a new diagnosis of HIV for someone who's getting injectable cabotegravir, unlike oral PrEP, which is like 30 days, as I said, it's more like 90 days. So people tend, based on the clinical trials with cabotegravir, so then people are kind of infected with HIV for 3 months before you know it, which is why I think. Oh, sorry, I think that's probably someone in the background. But anyway, so I think, what you said, I mean, is what I agree with, is that for injectable PrEP, it's more important than for oral PrEP for sure. Does that answer the question okay?
Yes, thank you. Reassuring. So I think I like, thank you.
Awesome. Other questions about PrEP before we move to DoxyPEP? Okay, there'll be time at the end too, so don't hesitate to save them up too. I love the interaction, so we can exchange in both directions here. Okay, so I don't have to talk about the epidemiology of STIs in Connecticut because that was done so beautifully right before my talk. But let me dive right into what's this very hot topic in STI care, which is this idea of doxycycline post-exposure prophylaxis, conveniently and cleverly named DoxyPEP. Can this be used to prevent new bacterial STIs, which of course has been a real challenge for many decades in this field? And this is the results of a study that were presented last year. The study hasn't been fully published. These are preliminary data, but they were presented at the International AIDS Conference and at a CDC consultation on DoxyPEP a few months ago. And the authors of the study were kind enough to share their primary data slides with me for this purpose. So the DoxyPEP study was conducted with open label doxycycline 200 milligrams taken as PEP, post-exposure prophylaxis, within 72 hours after condomless sexual contact, and the maximum of 200 milligrams every 24 hours. So if you had sex every day, they said, just take this no more than once a day. The inclusion criteria were you had to be male sex at birth, either living with HIV or on HIV PrEP, had at least one STI in the past 12 months, could be more, and condomal sex with at least one male partner in the past 12 months, could be more. And then the study, they did quarterly STI testing, the full suite, and they did GC culture before any treatment for GC in terms of looking for things like resistance. This was conducted at both the San Francisco Department of Public Health and the Seattle HIV and STI clinics. So settings not dissimilar from what an STI clinic might look like in Connecticut. And there was a 2-to-1 randomization. So they had about 400 people planned to be enrolled in the MSM and transgender women who were living with HIV, and about the same number for MSM and trans women on HIV PrEP. And they were going to look prospectively to see if it decreased incidence of new bacterial STIs, looking at GC, chlamydia, and syphilis. So what did they find? So the primary endpoint was a decreased incidence of a composite measure of all these 3 bacterial STIs. And what they found is that it had a very potent impact on incident STIs. So in terms of people on PrEP, it decreased incident STIs on a quarterly risk by 66%, so by 2/3, which is very dramatic. People living with HIV, about 62%. And in total, if you combine the 2 groups, it was 65%. So this is a real amazing result. And you can see these bar graphs. It's the PrEP cohort on the left, people living with HIV on the right. The blue is gonorrhea, the orange is chlamydia, the green is syphilis, and then the black are people who had more than one STIs. So you can see the PrEP cohort went from 32% of people with an STI versus, down to about 11%, and in the HIV cohort from 31% down to about 12%. So a major reduction. What about by specific agents? Because we know that there's been a history of resistance to tetracyclines, of which doxycycline is part of that class, for gonorrhea historically. It's not recommended as a first-line treatment for gonorrhea, of course. And so it turned out that it did actually decrease for all 3 of these bacterial STIs. So you can see in the little table broken down on the right here for GC, it decreased amongst the PrEP users gonorrhea infections by 55%, and similar 57% in people living with HIV. Chlamydia was even more dramatic, 88% in PrEP users and 74% for people with HIV, and syphilis, 87% and 77%. So really strong reductions in these bacterial STIs. And what about sexual behavior? So people at the time of enrollment, just to give you a sense of the characterization of people who entered the study and see how it fits with the clinical practice that people may see, in Connecticut and elsewhere. So people had a median of 9 sexual partners in the prior 5 months, and about 5 sexual acts per month, with 90% of sex as condomless, so very little condom use in this group. By self-report, there was no significant change in sexual behavior in terms of partnerships and condom use during the follow-up. Of course, if only 10% of people use condoms, you're probably not going to see a major reduction detectable, but those are still preliminary numbers. 86% of the people in the study used DoxyPEP always or often after anal or vaginal sex, and the median number of doses was 4 per month, but a quarter of the study population had over 10 doses per month. So for people who are more sexually active, they were using more DoxyPEP. And what they found, interestingly, because one of the questions here is about antimicrobial resistance. If we're using all these antibiotics, is that problematic? We'll talk about that in a second. but it did decrease ceftriaxone use, 50% less ceftriaxone use in the DoxyPEP arm because there were fewer infections that had to be treated by STI clinicians just as yourselves. And so that's a potential benefit too in terms of preserving ceftriaxone use. This is a little too detailed, I think, but the authors of the study went into more detail about whether symptomatic versus asymptomatic infections were presented. And if you just look at the summary at the bottom, I think that's the take-home point, is that DoxyPEP reduced the incidence of STIs that tend to be associated with greater morbidity, which is syphilis, which we know is problematic, and symptomatic rectal and urethral GC and chlamydia. But as is true in clinical practice, more than 80% of the rectal gonorrhea and chlamydia infections were fully asymptomatic, but DoxyPEP also reduced the incidence of asymptomatic infections. So both symptomatic, i.e. problematic, according to the authors, and asymptomatic. It seemed to work on both, which makes biomedical sense that it could potentially treat both. Big question is, will DoxyPEP promote antimicrobial resistance? And so they looked at the rates of gonococcal resistance to tetracyclines, which is important for a doxy-related intervention at baseline for people who screened for STIs at the start of the test and had positive tests for gonorrhea. And you can look at the bar charts here where the light gray is not resistant and the dark gray is resistant. So there were 99 people who had infections at baseline. They actually only had resistance data on about 17% of them. I don't know why they were missing so much. So it's a selected subsample of the data, but they did see about 25% of the people had baseline tetracycline resistance, which is very consistent with national rates in the US, which is about 20% based on CDC's the gonococcal surveillance project, the GISP data set. And but what they found in people who had incident gonorrhea infections, that number increased in the DoxyPEP study for people who use DoxyPEP to about 38% versus 12% of people not on DoxyPEP. But these are, again, very small numbers, just 13 incident infections where they had resistance data. So too small to know if it actually is promoting resistance in the context of its use. But in terms of sort of hypothetical discussions about resistance, we know in terms of gonorrhea, which is of the three agents, infections we're talking about, probably the most worrisome in terms of antibiotic resistance. We've lost many antibiotics over the past decades in terms of treatment, and drug exposure generally does result in resistance over time, with ceftriaxone being the one exception thus far. And so you can see these trends in the graphs from the year 2000 to 2020 in terms of resistance rates. Not surprisingly, Cipro, 40% resistant for gonorrhea, tetracyclines around the 20%, penicillins, again, which we don't use anymore because they're no longer necessarily reliable, but in the 15%. And then even azithro has climbed up, and I'll show you that in more granular detail here as kind of azithro is, I think, a good case study when you think about something like DoxyPEP. What happened when the CDC recommended that we pair azithromycin as empirical combination therapy with ceftriaxone for gonorrhea? And you can see here that started in 2010. And looking at MSM in specific in the context of a DoxyPEP talk here, rates of resistance went from less than 2% in 2010 to over 9% in 2020. And as everyone here knows, they withdrew that recommendation for empirical co-treatment with the azithro, in part for this reason. So will the same thing happen to DoxyPEP? Nobody knows, but definitely more studies needed. There's another study in CID, the clinical infectious diseases, that showed that recent exposure to azithro for gonorrhea treatments was associated with the resistance. So it's the same idea. Could DoxyPEP put itself out of business if you get exposed to doxy, and then when you're re-exposed to gonorrhea, you're seeing isolates that are no longer tetracycline, or in this case, doxycycline sensitive. So these are hypothetical considerations for gonorrhea, but doxy is also very important, as people here know for sure, for chlamydia, syphilis, and Mycoplasma genitalium. So for chlamydia, not a lot of data on resistance to doxycycline. The science in terms of testing is not really scaled up, but there have been some smaller studies that have shown that there have been higher doxy MICs in chlamydia treatment failures as opposed to chlamydia treatment successes when doxycycline is used as a treatment. Again, very small studies, and I won't go into the gory details here, but I posted some references and data for people who are more curious later. But we know doxy is a first-line treatment for chlamydia. So while it's not in clinical practice an issue with resistance, we do have to think about this for the future. Same thing for syphilis. We don't see issues with resistance to syphilis in terms of doxycycline thus far, but we know that macrolides like azithro can become resistant with a single point mutation and to the 16S RNA, to the ribosomal mechanism. And the same thing could happen with doxy and syphilis at any given time. So it hasn't happened yet as far as we know, but doxy is a primary non-beta-lactam treatment for syphilis. So we also have to think about how this could affect the availability of doxy for syphilis treatment when needed. And then finally, MGen, which is a really tricky infection to treat. There was another DoxyPEP study before the big one that I showed you the data for that happened in France as a sub-study of a PrEP study, much smaller with 210 patients. They had 11 patients who were positive in that study for Mycoplasma genitalium at baseline, and there was no change in rates of MGen with people who did or didn't use DoxyPEP, so it didn't seem to prevent new infections. But what they found is that there was high rates of resistance to azithro and quinolones, not surprisingly, in these MGen isolates. But there were 2 people who had incident MGen who were using DoxyPEP in the study, and they did find tetracycline resistance in these 2 patients. And so it's very, very small numbers, but the authors sort of highlighted that this certainly raises concern that having doxycycline around, even in the context of intermittent use of DoxyPEP, could potentially promote more resistance in MGen as well, which could complicate the use of doxy, which is not first-line treatment, but it is an alternative and is sometimes used to decrease the burden of infection before you introduce moxifloxacin. So all considerations that we need to think about when rolling out something like DoxyPEP. What about other flora like Staph aureus, which we use doxycycline to treat for things like skin and soft tissue infections? It's certainly not the only or first-line treatment for most staph infections, but it is something that we pull out of our pockets on occasion. And so people have looked at doxycycline when used for malaria prophylaxis in military staff who are overseas to see if, this is unrelated to DoxyPEP and STIs, but just to see if the use of long-term doxycycline promotes Staph aureus resistance. And this is a study of over 160 military personnel in Afghanistan, where they found about a quarter of people's Staph aureus, which was colonization and infection, had resistance to the tetracycline class. They didn't see any difference in resistance rates for people who were using anti-malaria prophylaxis with daily doxy versus those who didn't, which was reassuring. But they did some sequencing of something called the TET-M resistance genes in the doxy exposure group and the other groups. And they found that there was a higher rate of finding these resistance genes in the staph isolates when people had a lot of doxy use. So there may be subclinical resistance. So hard to know what that would mean in terms of people using DoxyPEP. But these are all things that I think CDC is considering before they make any formal recommendations, which I want to highlight. There are no recommendations thus far to start using DoxyPEP, but the CDC is certainly thinking about this, and I'm sure there will be guidance at some point soon. People have also looked at the question of, will this affect the gut microbiome? We have billions of bacteria in our guts that play an important role in the metabolic and immunologic milieu for humans. And some researchers have raised questions about whether all this antibiotic use could perturb the microbiome in a way that could be deleterious in terms of people's health. This is just a slide from Colleen Kelly at Emory, who gave a talk about the microbiome in the context of DoxyPEP at the CDC STD Prevention Conference at the end of September. And so her take, and it says my take on the slide, it's actually her take, and she let me borrow the slide because she's the expert here, is that you may see, and you probably would see, some perturbations that could lead to things like weight gain or maybe immunologic changes, but it's kind of a general theoretical change. But her take was that any harmful effects caused by changing the microbiome will probably need to outweigh the very significant clinical benefit of STI prevention that we saw from the DoxyPEP in order to make microbiome the reason that we don't roll this out. So more studies will be done and need to be done, but just to give an expert's take on this. So I won't go in great detail here, but I wanted to let you know that the San Francisco Department of Health which is one of the two DoxyPEP sites, has already released its own local interim guidelines for DoxyPEP use. And I know that they're using it. And I know that they have many dozens of people already using DoxyPEP. So, they're way ahead of the curve because they were part of the study. But just to give you a sense about how they're rolling it out, they're recommending DoxyPEP to any cisgender men or transgender women, just like the criteria for the clinical trial that I showed you, who've had a bacterial STI in the past year, have had condomless or oral or anal sex with at least one cisgender male or trans female partner in the past year, that are the same eligibility for getting into DoxyPEP study. They offer DoxyPEP in the context of shared decision-making, meaning that we know the data from this one study are preliminary and there could be concerns about antimicrobial resistance. There could be concerns about the microbiome. So we don't have all the answers. So there has to be a kind of shared decision where we go in to this decision as a clinician and a patient, knowing that there's some uncertainties, and make a decision together about whether it might be the right intervention for them. And they also mentioned that there is an ongoing RCT in Kenya that's looking at safety and efficacy of DoxyPEP for cisgender women, but because there are insufficient evidence now that they don't recommend people who have exclusively receptive vaginal sex to use DoxyPEP. We just don't have any clinical data at this point. So this is sort of coming attractions. The Julie Dombrowski, who was the PI for the Seattle site in the DoxyPEP study, also talked about her thoughts on who should be offered DoxyPEP, and wanted to let the world know that her belief is that we should get beyond the kind of we're for this or against it, like it's a great idea or it's a terrible idea, and think about whether we're going to use a more restrictive or a broader implementation framework. The broader framework would maybe meet patient demand, but have some issues with antimicrobial stewardship. But if we're more restrictive, we might not be covering all the people who could benefit from it. Could also create stigma if we only give it to certain subpopulations, and it could get complex as opposed to just offering it to larger populations. So more data and more guidance will certainly be needed. And Sarah Gantley in the chat mentions that it's frustrating that vagina owners that do not engage in receptive anal sex are often left out of these studies. It limits options and access. Could not agree with you more. And I know that the people who did the DoxyPEP study are absolutely sensitive to that issue. And I think they felt like in terms of getting buy-in and funding and stuff, that they probably had to start with one population that was receiving a lot of attention for bacterial STIs in the context of HIV and PrEP, and layered the DoxyPEP concept on those population studies. But glad to see that this is happening for cisgender women in Kenya, and hopefully those data will catch up soon, because the same thing happened for HIV PrEP, where it took a lot longer, I think, to get this on the ground for people with vaginas. So that's a welcome comment. Okay, so to get to the home stretch here, I won't go into the great detail here either, because this is in the future, but some counseling talking points that the STI clinicians in San Francisco use are to talk about sun sensitivity with Doxy. You have to remain upright for 30 minutes after taking it to reduce pill esophagitis. There are some rare complications like intracranial hypertension, which we don't see frequently. Just the usual counseling for anyone who's taking Doxy, and also that there are some unknowns about long-term use, as we've already talked about. This is just a screenshot of the kinds of patient handouts that they're preparing in San Francisco to give patients, what is DoxyPEP? Should I take it? What are we still learning? Some hotlines or warm lines at San Francisco DPH for DoxyPEP users. Okay, so my conclusions, so we can have a few minutes for questions. HIV incidence remains high. There are important inequities in terms of rates of new HIV infections by sexual orientation, gender identity, in terms of transgender populations having higher rates of new infections, substance use, race, ethnicity, and geography, all of which need to be addressed in general and with PrEP uptake to try and have the biggest impact and most equitable impact on the HIV epidemic. PrEP is safe, it's a highly effective tool, but it's been underused and inequitably so. There are oral and long-acting injectable PrEP options, and this is something that's, we definitely need to think about how to connect people from STI clinical sites to PrEP sites, because that's a population that could probably benefit most strongly from HIV PrEP interventions. undetectable equals untransmittable, U equals U is the real deal, zero risk of infections. You can say it loud and not be shy about it. And DoxyPEP is a hot new topic. It's safe, highly effective at decreasing important bacterial STIs amongst MSM and trans women who live with HIV or using PrEP. More studies need in terms of potential side effects and perturbations of the microbiome and resistance issues. And we're still waiting for CDC to issue formal guidance. And I'm going to thank the people who shared all their slides, who conducted all these great studies, and open this up to questions.
You can unmute yourself if you want to ask Dr. Krakower a question or put it in the chat.
Are you the great talk, Doug, and the great perspectives on the DoxyPEP. So the simple question is to put you on the spot. Are you doing DoxyPEP? And if not, then what might be your reason not to do?
Yeah, thanks, Amin. I love being put on the spot. No, this is a great question, and you're certainly not the first person to ask about this. I have prescribed DoxyPEP to a few people who are live with HIV, who I talked to about the results, and I'm probably at the upper end of the curve because I've been a part of the DoxyPEP conversations as the data were coming out. But I can tell you that one person was like, absolutely, I want that right now, even though there are uncertainties. Let's start. The other person said, well, I have to think about this. And the context here is these are people who had multiple bacterial STIs in the past years. So people for whom this type of benefit would probably be the highest. And so I felt like the shared decision-making was most useful. And then also someone on PrEP who had in the past 3 years has had about 8 or 9 bacterial STIs. And so I felt like at the upper end of potential exposures is having these conversations. But again, that's off guidance. And again, 2 people out of the 3 wanted to start it, and it's early days.
Thank you.
Of course. Other questions, comments? No question too large or small here.
Doug, we did have a comment in the chat a little earlier about the frustration of those that are vagina owners that aren't engaging in receptive anal sex, that are sometimes left out of these studies.
Yes, as I really appreciate that. I tried to mention briefly on the fly there that I could not agree more. And I think on the PrEP side of things, at this point we have data for people with vaginas, irrespective of any kind of sex. There are absolutely excellent PrEP options with daily TDF-FTC or injectable cabotegravir for people with vaginas. And so no hesitation of in fact, any sexual orientation, gender identity, anatomy, it all works with those agents. So that's the good news. For DoxyPEP, this is still like fresh off the press in terms of the MSM and transgender women that were studied. And I hope that the study from Kenya will be available soon. I don't know if the CDC will take a leap to additional populations around DoxyPEP prevention or not. But I agree that if this guidance comes out and it says, like it did, for example, for the Descovy for PrEP, that it's not going to be recommended for people who have receptive vaginal sex, that it's a huge disservice. And it frankly, not only for the population of patients, as a clinician, it makes things so much more complicated that it makes it harder to implement this in general and in specific. So I am totally with you. And I think advocacy of that nature is really important.
Any other questions? We have about another minute. Questions or comments for Dr. Krakower?
By the way, my mom lives in Stamford, and I told her I was talking to the Connecticut DPH. She said, "Can I come watch?" I said,
Oh,
"I think
I would have given her the link.
That's okay. You can imagine giving this talk with your mom watching from Stanford, probably not ideal. So, but I've spent much of my time in Stanford, Connecticut. So I'm really proud to be a part of this. And thank you for inviting me, Linda.
Well, we're so happy you were able to join us and give us the updates on PrEP and the exciting new information on DoxyPEP. You know, I know there's a lot to come down the road on this, but I wanted to make sure everybody had some information that they can start thinking about. So I'm really so grateful that you were able to present for us today. So thank you.
I have a quick question if you have a moment.
Sure.
In terms of prescribing PrEP to minors, I work in a high school. Is that allowed without parent permission? How do you go about that? Is, you know, without the parents either finding out or?
Yeah, that's a great question. I'm really glad you asked that. So daily TDF-FTC Truvada has been studied and is FDA approved for adolescents who weigh at least 35 kilograms or more. The same is true for injectable cabotegravir, FDA approved for that population. So it's definitely approved. There's no age requirement, but 35 kilos, whatever it is, like 80 pounds or so is the requirement. The issue around adolescent consent is very state dependent. And so because I don't know the exact details for Connecticut, I won't give the detail, but what I would say is that each state has its own kind of permissive, as you know, around sexual health care in general for like STI testing and treatment, but different states have interpreted that slightly differently for PrEP. So I would talk with either other experts here who may know the answer to that, or with sort of like the regulatory risk management people who may know more about the details to get a locally applicable answer. Some of the issues have come up around billing if people are adolescents and they have a parent's insurance as the source of their health care. And while we always say that, you know, the laws say that there shouldn't be any explanation of benefits that disclose what a certain visit or a lab test is for, that we know there have been issues where sometimes there's an accidental disclosure through explanations of benefits and things like that. So it gets a little bit murky, but I can say in Massachusetts, there's absolutely the ability to prescribe PrEP to adolescents with or without their parents' consent on a case-by-case basis.
And Doug, I'll just add to that in Connecticut, we also allow for PrEP dispensing without parents' consent.
Great, thank you, Linda.
If there's a financial barrier also, because most of my patients are underinsured or uninsured, how would they go about that?
Well, Siri, I think what we could do is we could talk. We have a PrEP coordinator here at the Department of Public Health, and we can certainly provide some more information about different ways of accessing PrEP if that's something that you're interested in. So please reach out, and what I'll do is I will give out my email address if you don't already have it, so that you can get in touch with us, because I think that's something that we could definitely follow up with you on.
Great, thank you so much.
Okay. All right. Well, we are actually a couple of